This is lecture 12, Cardiac Multi-Detector CT Clinical Appropriateness Criteria. In August of 2006, a paper was published on appropriateness criteria for cardiac computed tomography as well as cardiac magnetic resonance. And it involved a number of societies: American College of Cardiology, American College of Radiology, Society of Cardiovascular Computed Tomography, and a variety of interventional societies, including American Society of Nuclear Cardiology. All of these representatives got together and came up with what they felt were the most appropriate clinical applications. Now, what's an appropriate imaging study? That is their definition. It's an appropriate imaging study is one in which the expected incremental information combined with clinical judgment exceeds the negative consequences by a sufficiently wide margin for a specific indication for the procedure to be generally accepted as reasonable approach for reasonable care. Now, part of the problem, of course, is that it's very difficult to predict the future. So negative consequences include the risk of the procedure, that is the exposure to radiation or the use of contrast, and the downstream impact of poor test performance, such as delay in diagnosis, false negatives, or inappropriate diagnosis, false positives. So again, very important that you get the best images you can, and then you try to make the most appropriate diagnosis. However, the referral of the patient is also very important. So we need to now talk about what's the appropriate referrals for cardiac CT. Now, what they did is they came up with a variety of criteria. And based on the available literature at the time, now this again was a 2006 publication, so it was based on 2005 data. Over the past years, there have been considerably more papers published, but again, this is initially in 2005. They devised a rating system for appropriateness for cardiac CT. They decided something would be appropriate for a specific test indication by calling it A. Now that, if we talk about the class applications, would be roughly a class 1 application. U was assigned as uncertain, generally acceptable, but may be reasonable for the indication, and basically more research is required. So that would be sort of class 2A to 2B, and then finally inappropriate referral, not generally acceptable, which would be considered class 3. So let's talk about these kind of situations. In addition, because there's been so much happening, the Society of Cardiovascular Computed Tomography in 2009 put forward an international update based on literature up to the point of 2008 versus the 2005 data, and got a international multidisciplinary panel together to update the original appropriateness criteria. This is the publication. So they use the same criteria: appropriate, inappropriate, or uncertain, and basically they found no changes were suggested regarding studies that were considered inappropriate. They also indicated no changes were suggested for studies that were initially considered to be appropriate. However, several uncertain applications were made appropriate, and those will be discussed here. So first of all, let's talk about inappropriate indications for both these type of situations. For coronary artery calcium scoring, they felt that asymptomatic low-risk coronary artery disease. Now again, very important. Low risk means you've decided a Framingham situation for that particular patient. So asymptomatic low-risk situations for CT angiography, it was decided that if there was a high pretest probability of coronary disease, it would be inappropriate to get a CTA when in fact that patient needs to probably just go on for direct cardiac catheterization. Acute chest pain with ST segment elevation, patient needs to go to the cath lab. Asymptomatic patients at low or moderate risk, asymptomatic, these are considered to be inappropriate. Again, for indications for cardiac CT, the patient needs to be symptomatic, needs to have some sort of symptom that makes you suspect they have some pathologic cardiac problem. Moderate to severe ischemia on a stress test, the most appropriate thing in those patients is just to proceed to cardiac catheterization. Asymptomatic patient with a negative angiogram less than 2 years before. Asymptomatic individuals. Asymptomatic individuals with high calcium scores. Low risk non-cardiac surgery. So the patients, this is again non-cardiac surgery. Low risk individuals can proceed directly without having to have this kind of intermediate step. And asymptomatic patients after coronary bypass surgery or PCI. So it's just not patients that are curious about whether or not their grafts are open or whether or not you want to see if a stent is open or closed. Asymptomatic individuals would be inappropriate. So what about appropriate indications in 2006 and in 2009? So for chest pain, intermediate pretest probability or uninterpretable EKG or unable to exercise are considered appropriate suggestions for cardiac CT 2006 and were continued in 2008. Chest pain also for uninterpretable or equivocal prior stress test. This is probably the most common referral that we get in our laboratory for patients. They've gotten a stress test, it comes up with an equivocal result, and they decide to go to CT angiography. What about acute chest pain? Acute chest pain, for instance, the patients in the emergency department, if they have had presented with acute chest pain and they have an intermediate pretest probability or no EKG changes and negative cardiac enzymes, appropriate is very good to go forward for cardiac CT angiography. For acute chest pain in low pretest probability, no EKG changes or negative serial exams would also originally have been uncertain in 2006 and now has been made appropriate in 2008, 2009, 2010. For other indications for triple rule-out in acute setting, it was initially felt that this was an uncertain application in 2006, but with sufficient data that has come forward for this as well as for evaluation of bypass grafts in the setting of a chest pain syndrome, both of these now have been elevated to appropriate referrals. What about morphology? What about looking at cardiac morphologic, not looking specifically at the coronary arteries? A suspected coronary anomaly is considered an appropriate referral. Complex congenital heart disease, coronary anomalies again, abnormalities of the great vessels, abnormalities of the chambers, and abnormalities of the valves also are considered to be appropriate for cardiac CT. Evaluation of the pulmonary veins prior to invasive radiofrequency ablation for atrial fibrillation appropriate, and coronary vein mapping prior to biventricular pacer insertion also appropriate. What about evaluation of the coronary arteries in new onset congestive heart failure? This is a patient who has a low to intermediate risk of ischemic disease but still is presenting with heart failure. These would be considered to be appropriate. What about preoperative assessment? Coronary mapping to include internal mammaries prior to repeat CABG, very appropriate. Preoperative evaluation in intermediate high-risk patient before intermediate risk non-cardiac surgery, initially uncertain, now with sufficient data, has been considered to be an appropriate indication for cardiac CT. What about non-coronary applications? Aortic dissection, thoracic aneurysm, also very appropriate for applications, and of course looking for pulmonary emboli has always been considered an appropriate situation for CT angiography. Known suspected cardiac mass, where you have limited images from an MRI or a TEE or an echo, appropriate, and pericardial situations where we have limited images also from echo, MRI, or TE are both indications for cardiac CT. What about for screening? Well, screening is always an issue. This is the one that has changed. Coronary calcium for risk assessment in asymptomatic patient with an intermediate Framingham risk score has actually gone from uncertain to appropriate. The College of Cardiology has now put this at a class 2 indication for appropriateness for a referral regarding non-contrast CT examination.